My name's Dominic Power. I'm a consultant hand and peripheral nerve surgeon based in Birmingham in the UK, and I'm one of the editors for Orthoracal Hand, Wrist and Peripheral Nerve. This short talk is about entrapment of peripheral nerves, distal to a site of injury. Following a proximal peripheral nerve injury, either a disrupted nerve that needs repair or grafting, or a continuity lesion with an axonal low-grade injury that will have spontaneous recovery, the nerve as it progresses is more swollen. And this is because the regenerating axons have multiple filopodia at the growth cone and the nerve is swollen. In order to bring new organelles, cytoskeleton products and neurotransmitters to the growing end of the nerve, there is increased upregulation within the nucleus of the cell with increased transcription, translation of proteins, and there's increased transport along the cytoskeleton. Axoplasmic transport is susceptible to extrinsic compression. Now, as this large, swollen, regenerating nerve passes through naturally tight anatomical points, then it can become auto-compressed. What the peripheral nerve surgeon will note is that the patient reports higher levels of pain, the rate of the regenerating tunnel drops off or may even arrest at the point of compression, and ultimately the patient slows in their recovery. In such cases, I review the patients at 6-week intervals, and if the rate of tunnel is dropping off and remains very prominent at a tight point, I will discuss decompression of the nerve at that point with patients. Typical scenarios would be a medial cord brachial plexus injury, with approximately 6 months afterwards the patient developing irritation of the nerve in the cubital tunnel, and perhaps at 12 months irritation at Guillaume's canal. Or a median nerve injury at the mid-humeral level that's repaired, and the patient at 6 months develops irritation and entrapment at the lacertus fibrosus, pronator or the proximal FDS arch, and perhaps at 12 months irritation at the carpal canal. For the sciatic nerve, the perineal nerve can become entrapped at the perineal tunnel, or the superficial perineal nerve can become entrapped and irritated where it pierces the fascia 12 centimeters above the lateral malleolus, or the deep perineal nerve sensory branch can be irritated through the extensor retinaculum on the dorsum of the foot. The tibial component can be irritated under the soleus arch, or later in the recovery at the tarsal tunnel. Successful decompression of these branch points reduces pain, can improve sensation and motor function in cells that have regenerated but remain under a conduction block due to the extrinsic compression, and remarkable improvements can be seen in just a few weeks after decompression that cannot be explained by further neural regeneration. So in summary, I believe that decompression of regenerating peripheral nerves at naturally tight points of auto-compression is key to allowing continued recovery in those nerves and optimizing outcome for my patients.